Hello, and welcome to the Princeton Spine and Joint Center podcast. I'm Dr. Grant Cooper, the co-director of Princeton Spine and Joint Center. I just finished speaking with my good friend and colleague, Dr. Zinovy Meyler, who is the co-director of the interventional spine program at the Princeton Spine and Joint Center. We were talking today in depth about cervical radiculopathy, or a pinched nerve in the neck. So if you have neck pain or arm pain, we got way into the weeds on what is a cervical radiculopathy, the different how to think about it in terms of the different types of radiculopathies and radiculitis, what causes it, how do you come about to a diagnosis, how do you prevent it a little bit, and how do you treat it? And we got really into the biomechanics of why therapy is important and how we utilize it, and the ergonomics of daily life and computer use, and some of the interventional aspects of getting a pinched nerve better, like with injections and surgery, and when to think of which things. And it was a long conversation. We talked for about an hour and 20 minutes, and we got into the weeds on a lot of it. So if this is a topic that you're interested in, as I am, then I think you're really going to get a lot out of it and enjoy it. If this is not a topic you're interested in, then steer clear of this one. But if you or someone you care about has neck and arm pain, then I think you'll get a lot out of this. Welcome to the Princeton Spine and Joint Center podcast. I am Dr. Grant Cooper, the co-director of Princeton Spine and Joint Center, and I am very pleased to be joined today again by my friend and colleague, Dr. Zinovy Meyler, who is the co-director of our interventional spine program. Today, we're going to be talking about cervical radiculopathies. Cervical radiculopathies, Dr. Meyler. So, big word, cervical radiculopathies, essentially meaning pinched nerve in the neck, but we're going to nerd out a little bit and get into the details of what this really means and why that's important. So what is cervical radiculopathy? Why don't we start there?
Sure. So let's start with really nerding out and really going into the definition of it. So if you look at the word itself, it does imply certain things, and that is important. So the word really comes from two roots, Latin radix, which is the root, and pathos, which comes from Greek, meaning disease or suffering. So in other words, it's disease or suffering of the root of the nerve, and because we're talking about cervical spine, we're talking about a nerve in the neck that is being pinched or irritated and otherwise producing symptoms. And this is where it's important in terms of its definition, because we're going to contrast it with radiculitis.
So we have radiculopathy, which is a suffering nerve root in the neck. And now you're going to talk about radiculitis. Okay.
Yes. And in contrasting both, it would be better to use not so much the suffering, but the disease of the nerve, as opposed to the itis, which is the inflammation of the root of the nerve. And the difference really, if you delve deep into the definition and to deciphering the difference between the two, is that with radiculopathy, you don't have to necessarily have pain. It's really a disease of the nerve. In other words, it is lacking something, meaning what the nerve supplies is it supplies the nerve fibers for sensation. It supplies the nerve fibers for the muscle and the muscular movement. And so any disease of that or any lack of proper innervation will cause us to lose that. So in other words, it's a loss of sensation. It's a loss of strength, and it doesn't have to come with the pain. You could have painless loss of strength or painless numbness. The radiculitis, on the other hand, doesn't have to have the loss of strength or sensation. You could just be experiencing pain. You could experience the inflammatory parts of this. But we do tend to kind of group them together because there usually is a combination. It usually is a combination of the pain together with additional symptoms and with some, so what we call positive and negative symptoms, not in the sense of good or bad, but more so added to the normal. In other words, some things in this context, like pins and needles, which is not a common thing to feel, so it's an added sensation, or negative symptoms, in other words, those that are lost, so loss of sensation or loss of strength. And in fact, when talking about numbness, and we'll talk a bit more about that, sometimes it's a sensation of numbness without an actual loss of sensation, and sometimes it's an actual loss of sensation.
So in other words, someone so to parse that, somebody who has who reports a numbing feeling, you would characterize as different from somebody who, when you touch their skin, they don't actually feel it.
Yes.
And that's always something when we're doing a physical exam and you say, "Does this feel numb?" Sometimes people say, "Yes, it feels numb." No. Does it feel numb when I touch you? And those are two separate but related things, but separate.
Absolutely. And then, of course, that is where we make a distinction between symptoms and signs. And symptoms are something that the patient reports, and signs are something that we can objectively test. And then those, of course, are combined.
Right. So we've spent some time kind of parsing out radiculopathy from radiculitis. Are either of those in your mind, as you're orienting to a patient, more serious or less serious?
By themselves, not necessarily. It all depends within the context. But of course, whenever you think about radiculopathy and you start to lose function, then that becomes more worrisome, because now you have to look at it and see what is causing it and how much of that function is lost. Because now you're looking at it from the standpoint of restoration of that function, and how quickly we need to restore it. How quickly do we need to take that pressure off that nerve to restore the sensation or restore the function of the muscle.
Right. And for me, I always think of it as it implies a potential more of a impact on the nerve to actually get to a state of loss, as opposed to just inflammation. But then again, it depends, right? You can certainly have it either way.
A persistent loss, right?
Right.
Yes.
Yes,
Yeah,
absolutely. Do you and obviously these things often go hand in hand together, right? Mm-hmm. And while we're talking about cervical radiculopathy versus cervical radiculitis, a lot of times, especially if we're talking with non-interventional spine folks, we'll just say a pinched nerve in the neck, right? If we're, that's how a lot of people will think of it. And we're just parsing it out, because as we get deeper into it, it'll have clinical manifestations.
Relevance. Yes, absolutely.
All right. So what causes cervical radiculopathy versus cervical radiculitis? What are the different causes that you're thinking of with this?
So when talking about different causes, I'll take a sidestep for a second, and just to note the fact that a pinched nerve is not necessarily, so let's say a presentation of a pinched nerve, what we have to, and we'll talk about the diagnosis, we have to be aware that a pinched nerve is not necessarily a radiculopathy. So a pinched nerve can be not necessarily at the root of the nerve, but it can be further out. And we'll talk about that when we talk about how do we look at that. But to focus on...
Can I jump in for 1 second? I'm so sorry, because I realized I said pinched nerve because that's how we talk about it. But now I feel the just inside need to parse that and say, when we say pinched nerves, and even when we're throwing that around, it's really very rarely an actual pinched nerve, right? It's really an inflamed nerve, because we'll get into that too. I'm jumping the gun, but I just wanted to. The pinched nerve gives you a picture in your mind of a nerve actually being like choked off, and that happens sometimes. But it also happens where the nerve is just inflamed or irritated because it's being encroached upon, because the hole is more narrow and that. But sorry, I'm ahead of it.
Yep.
We'll come back
absolutely,
to it.
And that is actually part of what I was implying, is that it doesn't necessarily have to be pinched in the neck, but that inflammatory change can occur somewhere just outside of the neck, which makes it not a radiculopathy, but present like a radiculopathy.
Right.
So in terms of causes, so most commonly, we have to look at it from the perspective of age distribution. In other words, in different age groups, the causes are going to be somewhat different, or the likelihood of those causes is going to be different. So when you look at the younger population, 20s, 30s, 40s, you usually are going to see more traumatic or mild degenerative, but more traumatic in terms of discogenic type of changes. In other words, a herniated disc, a bulging disc, that will cause inflammation, and that will cause the symptoms. When you start to look beyond that age group and you're looking at the 6th, 7th decade and so on, the changes are going to be more degenerative, causing stenosis, which in essence means narrowing of the space. And that can be narrowing of the main canal, the central canal where the spinal cord runs and the spinal nerves actually come out of, or more commonly the foraminal stenosis, which the foramina are holes in our spinal column that allow the transmission or allow those nerves to come out and then continue on, eventually getting into our arms.
Right. All right. And so those are the causes in broad strokes. How do these things present usually? If someone comes in with different kinds of symptoms, what are you listening for when you're thinking cervical radiculitis or radiculopathy?
So if we were to look at a very clear textbook kind of a presentation, then it would be someone who has neck pain with radiating pain into the upper extremity, in other words, radiating pain into the arm. And that can extend into the shoulder, into the elbow, into the wrist, and into the fingers, or all the way down. Most commonly, textbook presentation would be someone coming in with neck pain, radiating pain into the arm in a nice pattern, what we call dermatomal distribution, where along the path of, let's pick a nerve, the more likely nerves to be involved are actually closer to the lower aspect of the cervical spine. So we're looking at C5, C6, C7, C6 and C7 more commonly of those. Then you'll see a distribution of the nerve going on the outside of the arm and then going into the forearm and so on. And that's the pain is going to be described as burning or electrical, and that's a very classic presentation. But go ahead.
If someone has a less classic presentation, they have the neck pain and the pain is going into the arm. Let's say they don't use the words burning. They just have a dull sensation going into the arm. Would that be consistent with or classic for radiculopathy, radiculitis?
It can be.
It can be. Right,
yes,
right.
it can be. That's the key.
I'm leading you, as you know.
Right. So it can be. The classic presentation, the textbook presentation, is really nice to see in a sense of diagnosing because it's very clear. But more commonly, it's going to be less textbook. It's going to be more tied in with other parts of the upper extremity. It's going to be tied in with different types of sensations. Nerves are responsible for any sensation that we perceive in the skin, in the muscle, and down the whole upper extremity. So in other words, they can mimic any of those sensations. They can also distribute differently. If we think of a nerve as a bundle of fibers, depending on which fiber within that bundle gets irritated and inflamed, that's what you're going to, or what the patient is going to be complaining about. So for instance, if there is a sensory nerve that gets affected, then it'll be a sensation or a lack of sensation. If this particular nerve goes to the shoulder, then the pain is going to be more pronounced in the shoulder. Or if it goes more towards the forearm, then that's where majority of the pain is going to be. So that pain doesn't have to be linear. It can be patchy. It can be the neck, the shoulder, then skip the arm, appear in the forearm, and so on.
Yeah, and I suppose, would it be fair to say that the less classic the symptoms of a cervical radiculitis or radiculopathy, the more you start to think, could this also be referred from other structures in the neck that make it seem like it could be like a cervical radiculopathy? Sorry, we use cervical radic often as a shorthand, but as a cervical radiculitis, but actually it may be just referred from the facet joint or from the disc itself or from some other structure, right? So we're always... Right. I'll just finish that thought. We're always thinking, of other possible things that might look like a radiculopathy, and the less classic, the more the antenna goes up for, okay, could this be referred from somewhere else?
Absolutely, and following along the same path, can this be from something else, or can there be a sort of a domino effect where the radiculopathy or radiculitis can cause a cascade of events where it causes one of two things. As we said, the nerve is responsible for motor control. So that motor control, in other words, how our muscles move, how synergistically they're moving, is going to spill over into control of different structures. So, for instance, our shoulder is a very mobile joint that depends on synchronization of the muscles that are supporting it for its support as well as motion. And all of that has to happen together. Certain parts need to be supporting, certain parts need to move. If that nerve, or in other words, if we can think of that as a wire that is a frayed wire, that's not transmitting the impulses as they should be, with the same synchronization as they should be going, you can develop, or you can see someone develop rotator cuff tendinopathy or any other tendinitis because of improper motion. By the same token, it doesn't have to be because of that, but it could be compensatory. So someone who's suffering from pain in certain positions will start to compensate by moving the arm in a different way, aggravating a different structure just because of compensation. And teasing those out can be difficult, but is very important, because we're now looking at a couple of things. We're looking at, like you said, any other structure that may mimic radiculopathy. Then we're looking for any other structures that may be affected by radiculopathy directly, as well as any other structure that may be indirectly affected as a compensation for the biomechanics.
Right. It gets nuanced. It's one of those things where, excuse me, I think that when it's clear, which sometimes someone clearly has a cervical radiculopathy and rotator cuff tendonitis, and so you clearly have to go about addressing both of those things. And sometimes, though, it's a lot less clear, and it's a lot more subtle, where the shoulder may be the most dominant presenting symptom. But once the shoulder is better, either from whatever intervention that you choose for that shoulder, if you fail to recognize that the neck was playing a role in that, you're sort of leaving it there to be set up for a re-injury on that shoulder, unless you use some kind of exercises or something to address the neck. To help let the nerves essentially talk better with the shoulder in the future.
Absolutely. In fact, a majority of orthopedic surgeons that specialize in shoulder surgeries, if there's any suspicion of cervical involvement, they will usually not operate, even on pretty clear injury to the rotator cuff that requires surgery, until the cervical symptoms are cleared up. Either they're identified or they're cleared up, because they know that having had that repair, it's so much more likely that it gets re-injured that they need to address the cervical radiculopathy first.
I saw someone today actually just with that. They have a rotator cuff tear. The surgeon is concerned about the neck and how it might be interplaying with that, and wanted to get the clearance on the neck before going forward with the shoulder.
Right.
I think to give the surgeons a lot of credit when they think of those things, because they recognize that to not sets it up for a possible problem in the future, which obviously they don't want. The patient doesn't want. Everyone only wants good outcomes. Yeah. Can you talk a little bit about double crush?
Yes. So double crush, generally speaking, it's what it sounds like. It's referring to the nerve. And in other words, crushing the nerve or affecting the nerve in more than one place. And most common presentation of that is going to be in carpal tunnel. Right, so someone who has carpal tunnel syndrome, which is an irritation, compression of the median nerve within the carpal tunnel, which is in the wrist. Very common for overuse injuries, like most commonly would be someone who spends time on the computer with poor ergonomics, sometimes actually with any kind of edema, any kind of swelling, very common in pregnancy, to have carpal tunnel syndrome. If there is other crushing of that nerve, in other words, other effect on the nerve, which, since we're talking about cervical radiculopathy,
Right.
would happen in the cervical spine, it predisposes, it sensitizes the nerve to being irritated further downstream. So in other words, if the nerve is pre-sensitized, it's injured already at its root, then it's going to be that much more susceptible to compression anywhere else, like in carpal tunnel syndrome.
Yeah, and sometimes, right, it's here too when people have carpal tunnel. I've seen it also when people have really bad carpal tunnel, but they need to check out the neck beforehand, and because if you don't, again, and you go forward and with a surgery on carpal tunnel, and it can lead to a bad outcome if you haven't recognized that there's more than one thing going on. Something that's a little less obvious, I think, and both you and I spent time at Sloan Kettering in our training, which is the famous cancer hospital, and with people who are having chemotherapy, and sometimes people that had side effects of the chemotherapy, and they would have numbness and tingling, chemotherapy-induced neuropathy, and there's not a lot that we had to offer that in terms of making the underlying problem get better with that. But sometimes those folks also had another peripheral nerve injury, like carpal tunnel, and you could make the peripheral nerve injury get better. And so by making the thing that you could make better, the overall symptoms get better, even though clearly the chemotherapy-induced neuropathy was the thing that pushed the cart over.
Right,
so to speak.
right. Yeah, absolutely.
Did I say that okay?
Yeah, absolutely. But the same thing that we've seen in post-radiation fibrosis,
Right.
same in slow Kettering, same also affecting the nerve sometimes,
Yeah.
sometimes crushing the nerves, not necessarily at the neck level, but just outside of the neck, and which actually happens a lot less now with more targeted radiation, and not to get
Right
completely
now,
off on the
I realize
tangent.
that I've
Yes.
dragged us a little bit, a little
Right.
downstream, but it's an interesting topic. The point,
Yeah.
the last thing I wanted to say about
Yeah.
that was just that it's so important because sometimes people have, for example, this is still in the chemotherapy-induced neuropathy, but I see it often enough that I think it's worth mentioning. People will have an intervention maybe from chemotherapy-induced neuropathy or something else or just a peripheral neuropathy where they just get numbness and tingling in their hands and they know it's a neuropathy. And often the neuropathy really is causing a lot of the symptoms, but sometimes it's the thing that pushed it over the edge, and there was an underlying carpal tunnel or cervical radiculopathy. And so by looking, and then you can address you maybe can't fix the neuropathy, but you can address the other nerve problem. It actually makes the symptoms a lot better.
Absolutely, and this kind of goes to just general thinking in medicine, right? So the usual thought is that kind of the holy grail of diagnosis is to find this unifying diagnosis. Here's this one thing
Right.
that causes all
The
this
silver
trickle down,
bullet.
yes, this trickle down effect. But even though that's great to find, sometimes two things do happen in parallel, and they do impact one another. So to your point,
Yeah.
finding
Yeah.
that additional thing, even if it reduces only partially
Right.
the symptoms, it can be significant in terms of quality of life, in terms of actual ability to do certain things.
You say it better than I do. That's good.
Because I don't think so. But because if you are talking about simple things that when we see with carpal tunnel syndrome or peripheral neuropathy, being able to handle a pen, being able to handle a spoon in eating soup, that is, if you improve that by 30, 40%, that's the difference between someone being able to feed themselves or struggling with the same. So even though it's only
Right.
partial, it's a significant improvement in the quality of life and ability to really participate. And that kind of trickles into psychological well-being and so on and so forth.
Exactly. All right, so that was a good segue into diagnosis. So
Yeah.
how do you go about diagnosing somebody with cervical radiculopathy?
So, as with anything, symptoms and history becomes very, very important. So, listening to the patient and figuring out what started as the initial symptom, which is not always very clear. So sometimes people will say that, well, I've had these patchy pain. So I've had shoulder pain, and then I had elbow pain, and it didn't make sense, and then some tingling, and when you're starting to piece it all together, it starts to make sense because now you can actually see, well, yes, that was all progression of beginning of the irritation and scaling up of that irritation of the root of the nerve that then progressed to a full radiculopathy that they finally decided that no, it needs medical attention. Listening, then of course diagnosing in other words physical examination goes to what we were talking about, the itis versus the pathos, and so inflammatory or pain and symptoms versus the lack or loss of something. This is where we figure out, does the patient actually have numbness and lack of sensation, or do they just feel like they're numb, as if the nerve is compressed, kind of like when they cross their legs and it's just falling asleep but just coming back?
I hate that feeling.
Nobody likes it. So if that's the feeling, then you actually you retain sensation. You actually can feel, but it feels like it's numb, or pins and needles. And then strength testing, objectively being able to test someone's strength, which is different than someone who's feeling somewhat weak. And then you can actually grade it, because we do have the grading system of being able to communicate one to another, of how much strength there is, and objectively being able to assess that. Within that context, it's important to remember that we are only seeing a patient for a glimpse of their day, and we are only able to test them within the confines of the time that we have. So besides the strength, there's also an element of early fatigue. So it is possible to test that, because someone who doesn't have actual strength deficits, in other words, no weakness, by testing their grip strength or testing their bicep strength or elbow flexor strength, if you ask them to do that a couple of times, all of a sudden you see a significant difference right from left, and that speaks for early fatigue. And once again, that's also already a loss, right? So that's also a loss of strength, just not something that's apparent right away, but more so needs more teasing out in the physical examination. Reflex changes, and so on. So within that realm, we can touch on some of the things that we look for when examining, because radiculopathy and loss of strength within the confines of an inflamed or irritated nerve root is something to pay attention to, but not necessarily something that's urgently needs attention or needs urgent steps to be taken. However, in physical examination, it's also very, very important to look at any red flags and to look at anything that would indicate that there's something more to this picture. There's something that's more urgent and needs to be addressed. So we look for upper motor neuron signs. So in other words, anything, when we talk about lower motor and upper motor, not to delve too deep into it. So we talk about nerves that are central nervous system before the synapse, before they connect to the nerves that are going to the periphery. So the nerve that actually exits the spinal canal is already a peripheral nerve, and that already made a connection to the central nerve that is in the spinal cord. If there is any effect on the upper motor neurons, then that becomes worrisome or concerning, because now we have to look for, well, can this be masking as something else? Can this present as radiculopathy, but in reality be something else? Or, just like we said before, it doesn't have to be a unifying diagnosis, but are we uncovering something that has been there, but now there is a pinched nerve on top of that? And now we have to look at this as two separate problems, interrelated.
But someone with an upper motor neuron sign would make you more concerned.
Yes, of course. So, and upper motor neuron signs would be teased out by symptoms to some extent, because if something doesn't follow a path of a nerve, then that of course always makes us more nervous about, well, is there more than one nerve involved, or is there a connection that's actually more central? Is it brain? Is it spinal cord? Are we looking at something that is really masking as something else? And just a couple of examples of, is this a compression of, instead of a compression and irritation of the nerve root, is it actually compression of the spinal cord? That can affect lower extremities and can affect gait, can affect strength and coordination. Is it something along the lines of multiple sclerosis that's affecting the rate of conduction of the nerves, and really more in the brain and the spinal cord? So all of those things can be teased out by the physical examination.
And just not to, and that's also one of the reasons why we will always ask about gait and fine motor control, right? Because those suggest the upper motor neuron, which put the antennas up even higher for upper motor neuron issues.
Yes, absolutely. And this is also to the point of discussing it with patients and discussing it with people. And of course, we always hope that we have a frank conversation with our patients, and our patients are going to follow our advice. Sometimes that doesn't happen. I know. So when it doesn't happen, we both get phone calls 3-6 months later that someone felt a little bit better, and now we've advised them to take certain steps, and they say, well, I'm ready to take those steps now. And usually we say, you need to come in so that we can examine, because nerve symptoms change, and as they change, they mature, they develop. So they may be presenting with something that's more advanced, or something that is a little bit different than we examined before, and the same treatment may not apply. So we have to re-examine and reevaluate and make sure that we're still dealing with the same issue, so that the same treatment plan still applies.
There's one provocative maneuver or special test that we will do with people that we're examining with cervical radiculopathy, called the Spurling's test. I think it's something that we always do, and it's for me it's an important physical exam finding. But also when I explain it to patients why it's positive or negative, it seems to resonate with them in a really easy to understand way. So I thought maybe can you explain Spurling's?
Sure, sure. So the idea is that we have these openings, right? The foramina. The openings are not just a hole in a bone. It is made by two vertebrae coming together with a disc between them, and they are mobile and they move. And that opening where the nerve comes out can change depending on the position of our head and of our neck. With the Spurling maneuver, what we're trying to accomplish is we're trying to create a narrowing of that space and simulate narrowed space around an already irritated nerve, because we're suspecting that this is radiculopathy. So if we are to compress that space, basically the way it's done is from neutral position, we will extend and side bend the head and then apply what's called axial force. So in other words, we're pressing down gently, always gently,
Always gently.
And always assuming that position always has to be done slowly. And so getting into that position slowly and then applying that axial force, essentially just pressing down, will cause narrowing of that space and theoretically will irritate the nerve. And so, as in our fellowship, we also used to do another maneuver, which is not as common and is not as validated as this, but the idea is very similar to what we do with lumbar radiculopathy or a pinched nerve in the lower back, where we have a straight leg raise. So we would extend the arm and turn the head, trying to create a small stretch of the nerve. And majority of the maneuvers are sort of accepted in medical literature as those that are defined and have been used and utilized over the years and validated to some extent. This is not. This is not one of those maneuvers, but it is commonly used. And the idea behind it is you're tugging on the sheath of the nerve, and if there's irritation, then it's going to recreate or irritate that nerve. Similarly, that if you were to have a scrape on your skin, if you were to move your shirt, all of a sudden that becomes very sensitive, and that reproduces some of the symptoms.
And for deep background on that, Dr. Meyler and I did our fellowships together, spaced out by a couple of years, but similar experiences. That was fantastic. All right, so you've done your history and you've examined the patient, including your maneuvers. How do you move forward in terms of establishing the diagnosis, or are you content now? Obviously, it depends. It's a little open-ended, but
it depends.
Take it where you will.
Right. It depends. So it depends mainly on. Well, it depends on a number of things. It depends on what we found on the physical examination. Do we have any red flags? Let's say we have no red flags. Let's say, because if we find any red flags, that takes us into a very different realm, and in terms of how quickly we take certain steps, in which direction we go, what we need to exclude first. Because just because there is a red flag does not mean that we've made a diagnosis, but it just raised suspicion. Right.
A red flag.
A red flag. It raised suspicion that there may be something else going on. And depending on what that leads us to believe it may be, then we may need to take different steps and quicker steps.
Right.
Generally speaking, if those don't appear on the physical examination or with symptoms that are described by the patient, then it depends then on the intensity of the pain, because we have to look at it and in the context of the patient, the quality of life, what they're able to do, what they need to do. Because in theory, ideally, the first thing that we do is we help control the pain, and controlling the pain can be done in escalating fashion. In other words, if you can use a small bucket of water to put out the fire, you don't bring out the fire hose. And that of course depends on the proportion to the extent of the pain and the extent that you can reproduce that pain on the physical examination. So if there is mild to moderate pain and limitation, then you can use nonsteroidal anti-inflammatory medications. You can use different modalities like ice and heat, all with the intention of getting the person into physical therapy. The physical therapy becomes very, very important in terms of treatment. Now, I've taken kind of a leap here, right? Because the diagnosis is not done. So I'm speaking about treatment within the confines of mild to moderate symptoms, the person's sleep is not affected to the point where they can't function and they can't sleep. They are able to function. They're experiencing these symptoms. We can address them. Now, if the symptoms are more involved, then not to go away from the diagnostics, let's talk about the other diagnostic steps that we can take.
Although, and the first person you were the first scenario with the mild to moderate is basically cervical radiculitis, right? Is what,
Yes.
what you're describing.
Yes, absolutely.
You
Yes.
haven't seen any real weakness. They're not, they're not numb to the touch. They're not dropping reflexes. So it's really not the pathos of the nerve. It's the
Right.
itis of the nerve.
Right.
Okay, so sorry, but back to the other scenario where you
The
have
other scenario,
someone.
yes. So when we're concerned with any loss of function, when we're concerned about other things that are happening, now we need to delve deeper into the diagnosis, because the clinical diagnosis through physical examination and everything else that we discussed is a very significant indicator, and usually is very accurate. What we haven't determined is what is actually causing this. We have our suspicions based on the statistics, based on what's more likely, depending on how old the patient is, depending on what predisposed the person, if there was trauma, et cetera, but we haven't really conclusively proven what is actually causing the nerve irritation. So to look at it, we can look at diagnostic imaging, and we can look at functional assessments. Right? So and that's an important distinction, because whenever you're looking at the imaging, you're really looking at the structure. The structural integrity can be looked at. If there was trauma, then of course you want to look at an X-ray, more commonly a CT scan, to make sure that there's no fracture, there are no fragments, etc. Usually that's done in the setting of an emergency room, because there's usually a more significant trauma, and they will rule that out more commonly before we see them. CT scan is a valid study, but when we're looking at, let's say, third and fourth decade, where the herniated disc is more likely, then structurally an ideal test is an MRI. So CT scan can be employed if an MRI is limited. So if someone has metal in their body, or for some reason cannot go through the MRI, then we can use a CT scan.
Right.
So an MRI will give us a structural assessment. What it's not going to tell us is the function, right? So it's not going to tell us what's happening to the nerve functionally. So generally speaking, whenever I'm talking to patients, what I usually tell them is, think of the MRI as a blueprint, or rather a picture of the house, right? So we've looked at the picture of the house, and we've seen where there may be some damage. And side note on that, we have to take any imaging with a grain of salt, right? And we talk about that a lot, because we know that if we take a population of 30-year-olds, and multiple studies have been done, and they don't exactly agree on the numbers, but the general number is about 50% of the people from 30-year-old group will have some small changes to their spine without necessarily any symptoms.
Right.
So the fact that someone has changes to their imaging, some changes to the picture, does not necessarily mean that every change is actually causing the symptoms. It's even more important when you start looking at the 6th and 7th and 8th decade, where the structural changes are almost inevitable. So not everything is going to actually cause symptoms. And that's where the functional assessment becomes even more important. So when you're looking at, going back to that analogy of the house and the picture of the house, the next step would be to actually look at, since we're talking about nerves and we're using the analogy of a wire, then you get an electrician in there, and you look for how are the wires actually functioning. And this is where at times we usually use nerve conduction studies to actually look at the function of the nerve. That becomes even more important when the picture is not textbook, when it's not clearly pinched nerve in the neck, or radiculopathy, cervical radiculopathy, since we defined that term. So what other things can we look for? Well, something that mimics pinched nerve in the neck can be a plexitis. Not a common thing, but well, to take a sidestep now.
What is plexitis?
Right. So the nerves leaving the spine form a web called brachial plexus. So the plexus is where the roots of the nerves intertwine, combine to form what's called terminal nerves, the nerves that will then continue on to the arm and hand and actually give us the function that we're testing and that we're experiencing in our daily lives. So that brachial plexitis, which is also
Can I
called...
break in there? Because I have an analogy that I like to use for that.
Go for it.
Which is that it's like a highway, right? So you have the central highway, which is the spinal cord. And then you have your off-ramp, which is the nerve root. And then you get all of those switchbacks that you get as all those bigger roads start to crisscross. That's the plexus.
Yes.
And then it shoots off into a single road. And now you're into your peripheral nerve.
Nice. That's a nice one. Yeah, that's nice.
I'm sure I stole that from someone, but I don't remember who, so I will just claim it for my own.
Yeah. Well, why not?
Sorry, Dr. Kahn and Dr. Gotlin, if you gave it to me. But sorry, so plexitis. So plexitis is inflammation of
the plexus. And so the plexus, the reason that intertwining or that highway mesh system is important is because depending on which part of the plexus, you can affect different nerves. And the way to test that is to use that sort of a electrical grid and to trace it back to whether it's the intertwining and combination of several nerves, or if it can really be traced all the way back to the root of the nerve. And also checking along the way if there's any additional compression of the nerve, talking about the double crush syndrome, perhaps in the axilla or the armpit, at the elbow, or towards the wrist. So any of the usual compression sites get checked with that test. That's a functional assessment. So now when you have the functional assessment with that test, you have the visual. Now you can put those together. So if you've excluded certain other compressions, and you've concluded that it's really a specific root, and the actual picture of that structure supports that, now you can be more certain about your diagnosis and what's causing that diagnosis. Where were we?
about being certain of what's causing that diagnosis.
Right. And also,
can I interject for one thing?
Yep.
Can you see a cervical radiculitis or radiculopathy in somebody where the imaging study is not that impressive?
Of course, because that goes.
Obviously, I'm leading you because
Yes.
we see it all the time, right?
Yeah.
And people come in frustrated sometimes because sometimes they've been told, well, your MRI looks good, so you're good, you know, and nothing is, I think, more infuriating to people when they're in a lot of pain, to be told, well, your anatomy in your neck looks good, so
Must be in your head.
Must be in your head. Must be in your head, I'll drop that off to you.
Yeah. So essentially, yes, it can be relatively benign. So you can have a mild change, which you can see in someone who's completely asymptomatic. In other words, no symptoms whatsoever. They're walking around with a slight bulging disc, for instance, and they have no symptoms. By the same token, the same picture can produce quite significant symptoms in terms of the itis, and sometimes even in terms of the apathy.
And this is where it's, to me, sorry to jump in again. It's just, this is where, it's so counterintuitive to the way that we as humans live our lives usually, which is, I have a pen, I drop it, it falls, and it's reproducible every time. But here you can have an MRI that looks terrible with a huge herniation and have zero symptoms, right? And by the same token, you can have an MRI that looks benign. I mean, I would argue, pretty much normal, and yet you can have a really bad radiculitis, presumably, because what's actually causing the symptoms for the majority of people is if there's an inflammatory reaction, and it's that inflammation that's then causing these kinds of symptoms for most people.
Right. And that's also partially why some people will feel fluctuation. It's not going to be sort of this persistent pain at a level of 8 out of 10 is going to fluctuate. And that fluctuation has a lot to do with inflammatory fluctuations, and has a lot to do with the inflammation of the tissues around the nerve that also can swell up and cause mechanical compression, as well as the direct irritation to the nerve. And the fluctuation, sort of that ebb and flow of the inflammation will cause that also frustrating a lot of times.
People are always frustrated. They're always, and one of the only things that sometimes I can say to folks is, look, we don't always know what causes, daily fluctuations. Why is it worse tomorrow, and then it's better the day before, and worse again the next day? And when the person's saying they're doing the same thing every day and they can't identify a triggering factor, And it's one of those things where we see that with knees and hips and backs and necks.
Right.
And it's probably something to do with the pressure outside and their diet and how they're sleeping and small little things. But what it's really representing is what you're saying, which is the undulating factor of the inflammation coming and going.
Right. Right.
So that's also why, when we see patients, I almost never ask, how are you feeling? If I'm trying to get a sense of how they're doing, I'm asking them, how have you been feeling in the last week or two, to get more of a gestalt of how is the general picture? Because at any given moment, they may feel great, they may feel terrible,
Right.
but that doesn't necessarily reflect how they're overall doing.
Right. And we don't have what we have for diabetic patients, which is hemoglobin A1C, where we can
Right.
get an aggregate of 3 months. We don't have
Yes.
that, so we have to ask and we have to see and have those conversations. Like you said, it's usually multifactorial. It's usually not going to be, like you said, dropping a pen and reproducible. It's usually going to come from a number of different factors, which we have to address in terms of treatment. So why don't we go into
Good segue into treatment, thank you.
So, before we go into treatment, so
Please.
to talk about the diagnosis and to just touch on some of those things that we talked about as far as red flags go, and as far as other entities that we may find that may mask themselves or present themselves as radiculopathy. MRI, nerve conduction study, besides the physical examination, are also going to really shine a light on those things. So for some things, nerve conduction study is expected to be completely normal, which actually does support certain things. Let's say, for instance, if we're suspicious of something that is sometimes a bit frustrating to diagnose, let's say something like multiple sclerosis, where there are no lesions on the MRI, but if we have a nerve conduction study that is really normal, because we're checking the peripheral nerves, that is not a completely a study that rules things out, but it actually goes in support of that diagnosis that we're suspicious of, and that we can keep on going and looking at.
Probably a good moment to note that the electrical diagnostic studies are looking at the peripheral nerves.
Yes.
Right. They're not able to look at the central nervous system, which is why sometimes sometimes when people have a cervical radiculopathy and you're trying to distinguish it from a myelopathy, and you get a nerve test, you almost want to see the findings change on the nerve test to support the idea that this is really from the nerve roots rather than the central nervous system. Because if it's totally normal, it starts to suggest that it's more of an upper motor neuron issue, which is a more difficult, a more serious problem.
And since you brought up myelopathy, let's just define myelopathy.
Oh, sorry, please. Yes, thank you.
So because not everyone knows.
Yes.
So myelopathy really implies any symptoms that will come from compression of the spinal cord, or any upper motor neuron symptoms, and those can be a myriad of things. And usually it's going to be coordination effect on the gait. So in other words, the way we check is just like sobriety test on the side of the road, heel to toe walking. General walking, coordination of the lower extremities, upper motor neuron signs like reflexes, Babinski, Hoffman's, etc.
Right,
so that's what myelopathy is, and that is distinctly different from radiculopathy, because it's affecting the upper motor neurons, as opposed to radiculopathy, which is affecting the root of the peripheral nerve.
Right.
So.
Good segue to treatment or more red flags?
No, I think so. I think
segue treatment. Segue treatment.
So as we started talking about that, the treatment of mild to moderate type of symptoms will be mild to moderate. Essentially, we can be conservative and we can look to medications. So non-steroidal anti-inflammatories, to some extent for anti-inflammatory effect, to some extent for the pain reducing effect. All of that is not to really cover up the pain, but really to make someone a bit more functional, to be able to function during the day and actually be able to participate in physical therapy.
Right. I mean, for my you've heard me say this a million times when we've talked about it. There's such low penetration of oral medications into the spine that when people take Advil or Aleve or any number of different non-steroidal anti-inflammatory drugs, for me, it's really more about pain control rather than the anti-inflammatory effect, although there is some slight anti-inflammatory effect. But like if somebody had a bad cervical radiculitis and they took Advil for 2 weeks and they felt good, and after the 2 weeks, their cervical radiculitis was all better, a logical conclusion would be that the Advil had fixed their cervical radiculitis, but a more correct, explanation would be that 2 weeks fixed their cervical radiculitis, and the Advil made them feel better while those 2 weeks was transferred, which is fine. Which is
Yeah.
to your point. It's just about managing the symptoms to enable them to be more active. Sorry, pet peeve.
Absolutely.
I had
Well,
to
well,
insert
that is there is a lot to tincture of time in the first week to 2 weeks of experiencing these symptoms,
Yeah.
and controlling the symptoms. Like you said, that may make enough of a difference for people to be able to function during that time, and actually start taking constructive steps in terms of reducing their pain and the source of that pain. In a similar fashion, so why do we do physical therapy, right? Why do we
Why do we?
prescribe physical therapy? Same reason why we do Spurling maneuver. So Spurling maneuver is putting someone at a disadvantage and actually irritating those nerves. And as we said, the radiculopathy usually is multifactorial. So usually it's multiple different factors, and usually there is going to be and I'm sure you do as well, get that question a lot. Well, is it hereditary? I mean, my brother has the same thing, or my father had a similar thing. So, and the answer to that is not clear cut, right? I mean, it's heredity is
Probably.
right.
Right.
Heredity is a difficult thing to answer because what you inherit can be broken down into two things. It can be broken down into genes, right? So genetically, I mean, our structure comes from the genes. So by definition, yes. So we've inherited the spine that came from the genes, from the genetic code. But by the same token, that's not the whole thing, because we also inherit by just mimicking and learning about walking and posture from our parents, from our older siblings. So we inherit that as well.
Not to mention our habits. You were about to say that.
Yeah.
I'm sorry. Yeah.
So habits and posture, all of it, because it's multifactorial, all plays into this, which is where the physical therapy and ergonomics come in. So physical therapy is meant to really create the support for the spine in a proper way. So evolutionary, we have a number of different muscles that we simply don't use properly because we're not using our posture properly. We're not properly, right? That makes me remember it all.
We're both, for those just listening, we are both sitting up straight now.
Right. Straighter than before.
Straighter than before.
The posture becomes an important thing, and we have a number of muscles that we don't engage appropriately. They're postural muscles, and when we don't, then that puts our spine at a disadvantage, and it does so in multiple different ways. So. One of the analogies that we both like is the mast on the ship, where the only way that the mast is actually on a sailboat is able to not only keep its weight up but also propel the whole boat is by the shrouds. In other words, the lines, the ropes that keep it up with proper tension. So the same goes for our spine. When those ropes are not properly tensioned, when the spine is not supported well, then bad things happen. And those bad things, basically, when other muscles are forced to chime in and support the head, which we can think about the head as weighing similar to a bowling ball, right? And I know we use that analogy all the time.
I was waiting for that one. Yes, it's a good one though. It's a good.
So if you, because we have cameras, I'm going to demonstrate. Essentially, what we're asking our necks to do is to hold a bowling ball like this. In other words, suspend it straight up in the air.
Dr. Meyler is now holding his hand over his head.
What is happening with poor posture is that we fall into what's called anterior carry. And anterior carry just basically means, when we say anterior carry, we talk about the plumb line. And the plumb line, ideally, you'll have your earlobe over your shoulder and going down and supporting your spine. That lines our spines ideally so that all the muscles are properly tensioned, all the muscles are working in synchrony, and not one is being overpowered by the other, and the actual structure of the spine is able to be at its optimal supporting role. When we slouch, what we have to do is we now have to get our head forward in order to actually look straight. Otherwise, we'd be looking at the ground. So because of that, we're creating anterior carry. That anterior carry, essentially what we're asking our neck to do now is, instead of carrying the bowling ball directly above our head, now we're carrying it in front.
So much harder.
It is much harder. And that's what now compresses the neck, because at some point those muscles will fatigue, and now the structure of the spine, it gets compressed because there's poor support. And that creates a cascade of additional poor posture, additional strain on different muscles. That's why a lot of people will come with pain in their between their shoulder blades, because now there are all these compensatory mechanisms.
Right.
So whenever the treatment becomes talking about the habits, talking about proper posture. All of us are using computers one way or another, whether we're behind the computer all of our days, or we're using it to document like we do, or we're looking things up, or for any number of reasons, we are sitting in front of the screen. And it becomes that much more important to look at the way we sit in front of our screens. We know that our heads will follow our eyes, and our neck will follow our head, and our shoulders will follow in suit. So what tends to happen is if you find that your line of sight is parallel to where what you're looking at is, you're much more likely to sit up straight. What most commonly happens is that the computer screen is just slightly lower, and the center of the screen is where majority of our work is going to be done, is going to be a little lower than our line of sight, which brings our eyes down, which allows our head to follow, which allows our shoulders to follow.
So sad as you're showing this. Yeah.
Yes. And then what happens is we dive into our work figuratively, but then literally start to dive into the computer, and now we're in a poor posture. And unfortunately, what tends to happen is that we can keep good posture for the first couple of minutes of being aware of it, but then we dive into our project, and then we spend hours in this kind of a.
And to me, that means there's two things that you need to do when you're looking to address it. One is to address your computer screen, which is what you were getting at, right? Just to get it to the right eye level, so that you naturally want to sit up straight. The other, though, is also the therapy that you were talking about, right? To train the muscles so that they're ready and they want to be in the right position, right? Because the other thing is we tend to exercise the things that we can see in the mirror, and we tend to, and that tends to lead to these slooping shoulders, and we don't tend to exercise our back and the small muscles in our back, the rhomboids and the postural muscles. And so by exercising those through the right kinds of therapeutic exercises, it makes it so you want to sit, you want to carry yourself more in that correct posture. And then that, and being aware and setting things up around you right, comes together, right?
Absolutely, yes. It's really, it comes down to training, and really re-educating our spines and our posture, and at the same time creating enough of triggers in our environment to remind us. So, for instance, another one a piece of advice that I usually say is when you get in the car, because inevitably majority of the population that works will end up commuting for a large part of the day. So people commute anywhere between an hour to 3 hours, and some people
3 hours
driving. And if we're talking about how our postures are in the car, ideally, what I would recommend is sitting up straight, making sure that you're properly supported with your seat and feel upright and comfortable, and then adjusting the mirrors. And then not touching the mirrors again. Because the next time you reach for the mirror, that should be a reminder that you probably are slouching and you're not actually in need of adjusting.
This is good work. That is fantastic. I'm definitely going to use that with that's really, I'm going to use it for myself.
And so basically just any triggers in the environment to adjust the posture, and then do the physical therapy. So, and that's where the physical therapy becomes important. And
it's worth noting just there too that, the therapy, a lot of times when you have people who are in really good shape and you say therapy and they say, well, I already work out. We have professional athletes of all stripes that benefit from therapy for this kind of thing, because sometimes even when you have really strong shoulders and really strong chest and even really strong back, still it's those small postural muscles that need the attention and the awareness. And people who are really used to working out might pick it up faster, but it's really important that they still pay that attention. They can still benefit from it, and it usually pays dividend in their sport or activity, just from having paid attention to it.
Absolutely, and it actually is the study that we've talked about a number of times, and we talk to our patients about, which I'm used to saying 5 years, but I believe it's 7 years ago now, was published.
Getting older.
Yeah, was published in the British Journal of Sports Medicine, where cricket players, this is England, so cricket players are professional athletes, were taken, and this is looking at the lower spine, so lumbar spine. But it's still a very good example of really looking at someone who's athletically fit, and so someone who does that for a living, who's an athlete as a professional. And what they did is they looked at the professionals, and they used the EMG, which is electromyography, testing the supporting muscles of the spine to see how they trigger the muscles. And surprisingly, or not surprisingly, less than 50% of those studied actually trigger the muscle support that support the spine appropriately, which really does two things. And number one, it underscores the fact that you can be as fit as anyone and still not properly support the spine. And number two is, if the athletes don't then the rest of us have no chance unless we really address and really go after those muscles. So I like that study to illustrate it to the weekend warriors.
It really does. And I mean, on an anecdotal level, excuse me, end of day. We both have so many stories of athletes who we had to sort of cajole into doing the therapy because they spend all their days working out anyway. And then when they do the therapy, whether it's the back or the neck, a lot of times, not always, but a lot of times they come back and say, that really helped my sport also, because they do start firing all those small muscles, which pay dividends down the road.
Yeah, and freeing up the other muscles that were contributing to the support.
Right, that were compensating. Yeah, exactly.
Now they're free to do their function.
Right. But you're right. The rest of us, we really need to
really address it.
Address it, yes. So that's therapy. We got into that pretty deep. For the mild to moderate, we were talking about, we try to control their pain, get them into physical therapy. What about with people who are in too much pain to go to therapy, or they go and I'll give you both, or you can take it wherever you want. People who have been to therapy and for whatever reason the pain is still hanging on.
Right. So those two examples. One example of, and we can group them for the purpose of illustrating the other treatment options, is someone who has done physical therapy or someone who has tried physical therapy, and the physical therapy itself either is the patient is not able to participate in physical therapy because of the intensity of the pain, or the physical therapy actually aggravates the symptoms. So in that situation, we have to look at it from what is driving this, right? What is stopping them from progressing? What is stopping the progress, whether it's beyond a certain plateau in physical therapy or even not letting them participate in physical therapy? And usually it's going to be inflammation, right? And inflaming the nerve. And in this situation, like you mentioned, the non-steroidal anti-inflammatories, even oral steroids, sometimes we'll have a hard time putting down that fire. And I know that we both like to use inflammation and fire kind of interchangeably, or as an illustration of what's happening. The reason that it's not going to be very effective is that, and not to say that it's not. So sometimes the oral steroids can reduce the extent of the inflammation. But the reason that they are not effective sometimes, and the reason that the non-steroidal anti-inflammatories are not very effective for anti-inflammatory effect, has to do with distribution. Has to do with the fact that when we take the medication orally, it has to get absorbed. There is a loss to the absorption, so not everything gets absorbed. Then it has to get into the bloodstream and distributed. And distribution can be really linked to your analogy of the highway. It's, if there isn't a good road to the place, it's just not going to get there.
Right.
And unfortunately, to the spine, the deeper we get into the spine, the less direct blood supply there is. So in other words, you're diluting what you're putting in significantly, first by how much gets into your system, into the bloodstream, and then how much actually gets delivered to the place that you need it the most. So what do we do at that point? Well, in that situation, we can deliver the medication directly to the area of concern. In other words, into the epidural space. What is an epidural space?
How do you do that? Or what is
So what is, and this is, I think that this is an important definition to bring up here, because we get asked the question, well, can you do a cortisone shot or an epidural? What is it? And that gets used interchangeably, a lot of times inappropriately, so it bears to really just define it. So epidural space. Dura is the covering, the outside covering of the spinal cord and spinal nerves. Epidural space is where majority of the inflammation happens. It's the space above the dura, as implied, epi, right? So epidural space, and it is a lower pressure environment where there's loose fatty tissue, and that's where majority of the inflammation happens. So that's where we put the medication when we need to deliver it directly where the inflammation is. Once again, there is some misconception of putting medication into the nerve or into the disc. That doesn't happen for what we're talking about. So when there's inflammation around the root of the nerve, you put the medication around the root of the nerve, and that happens to be into the epidural space. So whenever.
And just in case we didn't say it before, we're talking about using we're talking about injections,
right?
I don't know if we
didn't get to that yet.
Yeah.
So basically, delivering the medication directly, and the only way to do that is bypassing the circulation, bypassing the oral.
You were going there.
So the way to bypass that is to actually deliver it directly, and of course, the only way to do that is with an injection. So essentially, you take a needle, and with guidance, it has to be in a very controlled environment under the guidance of fluoroscopy, which is a modified X-ray technology that allows us to use live feed. In other words, you can use sequential imaging, so one snap of the picture after another to see where you are, or you can use live feed. And usually for something like this, we use both. So we'll use step-by-step approach to identify the structures. All of that is done in conjunction of everything else that we've done so far. MRI, nerve conduction study, if appropriate, if needed, physical examination, so we know where we're going. Now we're looking at the structure directly. We see where the needle is, and then we can guide it directly where we need it to go. Then we will confirm the placement with contrast by allowing that contrast to flow, because the medication is not something, it's what's called radiolucent. In other words, it's transparent to fluoroscopy or to X-ray. So we wouldn't be able to see where that medication goes. So we use a small amount of dye to actually outline where that medication is going to go. Once we're happy, what does that mean? What makes us happy? So when we are convinced that we're in the proper place, the structures are clearly identified, and then the contrast flows where we want it to go, and at the same time doesn't flow anywhere we don't want it to go. So, and here, of course, the major concern is blood vessels, especially in the cervical spine. The blood vessels, there are multiple different blood vessels that we go around and make sure that we don't actually put the medication into the blood vessels. For one, it makes the medication a lot less effective because it's going elsewhere, and number two, it shouldn't be there. So the contrast allows us to see both. It allows us to see whether the medication is flowing where we want it to be, and that it's not being taken up by anywhere else or any other structure, and then we put the medication in. And the medication is going to be a combination of corticosteroid and sometimes anesthetic, sometimes just a small amount of saline to carry it in, depending on what structure and what approach we're taking. So there are two major approaches to this. One is called interlaminar, and the other one is transforaminal. And what it refers to is the structures that we're going into. Transforaminal, as we've talked about the foramina, which is the opening on the sides of the spine where the nerves come out. We can approach it through the opening and put the medication in that opening, or we can go interlaminar, which is between the lamina or the posterior, the back of the spine, and go midline. Well, we go slightly off the center, end up midline, and then place the medication and allow it to flow up and down, getting to both left and right side.
And again, the advantage here is that you're able to deliver the medication that you actually want to the space that you want it, which is one of the reasons why getting the diagnosis right is so important. And there was that study, I was going to say 5 years ago, but now I'm going to have to say it's more than that. But where they showed that by using electrodiagnostic studies to identify the nerve root that was actually impacted, because sometimes from the MRI it's not so clear. Maybe even often, you could say, people ended up needing significantly fewer injections because you were able to get it more to the space that you want it and not waste it in the spaces that you didn't want it. So just again, getting back to, the more accurate the diagnosis, the more specific and targeted the therapy can be. And in some ways, I mean, you could, in some ways, injecting the corticosteroid is less invasive, to me anyway, than taking it orally, because you get the medicine only where you want it and not where you don't. On the other hand, you're doing an injection. Obviously, that's more invasive than just taking something by mouth. So, there's pluses and minuses depending on the situation.
Right, absolutely. And so
So so now you've had this person with a cervical radiculopathy or radiculitis, and you've done this injection. Did you fix it?
good question. So fixing it, curing it, and many other terms that are used. So
Yeah.
we have to be careful about the terminology because it has certain implications. And so what are we really doing? And so what we're trying to do, right, is we're trying to reduce the effect on the nerve. There isn't anything within the confines of evidence-based medicine that we can use right now that really heals the nerve. The body really heals the nerve. The nerve is
I was
constantly
about to
trying
disagree
to.
with you until you went there. Okay, good, good, yes.
The nerve is constantly trying to recover itself.
Right. Can I interject? Because in a
Go
sense, I
ahead.
think what you're saying is that our job as the interventional physicians in this instance is to create the space for the body to heal itself.
Yes, yes. To remove any offending structures or any offending processes that prevent the normal healing from taking place, which is normally what your body is trying to do. And the only
Interesting way
thing
of
that
thinking of it. I like it.
the only way that we can approach it is by taking away the offending thing. And I'm going to
Right.
say thing in a very general term
Well, the thing
because
is two things here, right? Thing is, one is the inflammation,
right.
and that's where the sorry, microphone. That's where the injection or possibly oral steroids come into play. And then the other thing is what you were talking about before with the posture and the exercises.
Yep.
Which is what actually takes the pressure off of what caused the inflammation in the first place.
Yes, absolutely. And in fact, so we're talking about minimally invasive. We're talking about conservative measures. Even these interventions are considered to be conservative measures and conservative ways of treating because you're not actually changing the supporting structures. But even if you do think about surgery, what is the surgery really doing? The surgery only aims to take away the offending structures, and this
Right.
is where the thing, in a very general sense of the word, inflammation versus the structure. So any time that we're trying to affect anything, it's really trying to, like you said, create the space where the healing can take place.
Right. And so if we just back up two spaces, you do the injection,
Hmm.
and then let's say you do this epidural steroid injection, and a couple weeks later the patient comes back and says, I'm 90% better. This is great. Fantastic. Am I done? Am I cured? Is that great?
Of course.
Of course it's great. But what next?
Well, so statistics, right? Statistics are only important for expectations and what we can expect. So statistically, we know that that it may take anywhere between 2 and 3 treatments to actually get the symptoms under good control in the setting of radiculopathy or radiculitis. For that
You're talking
matter.
about maybe doing, if the person comes back and says, I'm 50% better, then you're
Right.
going to want to repeat that injection because you want them to be at least 90% better.
Right. Potentially, right?
Potentially.
So it all depends. And statistics don't apply to individuals. So
Right.
so we have to be mindful of the statistics, but we have to be even more mindful of the context of the individual that is in front of us.
100%.
And so
Take care of people, not MRIs.
exactly. So within that context, someone comes back, whether it's after the first injection or the second injection, and they are significantly better. So just to take one small step back for a second, if why does it take 2 or 3 injections? The theory behind that is that inflammation comes in layers, and by putting the corticosteroid in the place of inflammation, what we're trying to do is almost like peeling an onion. We're taking the layers of inflammation off to the point where the person feels better. Now, our aim is not 100% improvement, and if it's not 100%, then we're going to keep on going.
Right. Our aim is always 100% improvement, but
Eventually,
realistically, we want, right. Exactly. Yeah.
Yeah, so what we're trying to do is we're trying to create a momentum and trying to create a space
Right.
where the person creates a momentum of improvement
Yes.
where they are significantly better, and then to pick up to your
Yes,
question
yes.
of what happens now, 90% better, cured or fixed. Not exactly, right? Because what we've done is we've put out the fire. And in our analogy of the fire, if you were just to do the injection and say done, you're cured. Even if the person is 100%, it would be analogous to coming up to the fire, spraying it with a fire extinguisher, never coming close to it, dropping the fire extinguisher, turning around and walking away. The embers are still there. The reason for the fire is still not...
The lighter fluid bottle is still sitting right next to it.
Right. So the likelihood and the chances of that fire restarting again are significantly high, that you cannot walk away. You cannot just kind of wash your hands and say, that's it, we're done. So we're really now kind of looping back to what we started talking about, which is the ergonomics, the physical therapy. And having that conversation is even more important at that point, because as we all know very well, pain is a great motivator. The motivation is there when the pain is there. As the pain starts to fade, unfortunately, the motivation starts to fade as well. And when we're talking about the motivation, of course, I'm referring to the exercises, the therapeutic exercises, the ergonomics, and watching your posture, everything that usually leads up to the problem that we're dealing with.
The eat your vegetables moment. Which doesn't have to be all encompassing, right? That's the thing. I think sometimes people with the exercises, they feel intimidated, or it seems like too much, and they don't realize that they really can get down to maybe 10 or 15 minutes a day, and it's going to help them in other parts of their life. They just have to make it a habit, right? And so, but back to your point, you've done this injection to create this window of opportunity, basically, to allow someone the space to go do the exercises to help prevent it from coming back. I use the analogy here of someone putting in a stent. Someone goes to the emergency room with a heart attack and they put a stent in. Did they fix it? Sort of, yeah, they did fix it, right? They didn't mask your heart attack. Your heart attack's gone. When you inject someone, you didn't mask the person's symptoms. Steroids don't mask pain. They take away the inflammation, which is what was causing the pain. By the same token, if the person then goes home from the emergency room and says, great, I'm done, fantastic, they're probably coming back in 3 to 6 months with another heart attack for another stent, right? So no one would ever do that. It's ridiculous. You would go on a statin or a blood thinner, and they'd give you medicine to address the underlying cholesterol that likely led to the clot in the first place. Here, that the analogy there is just, instead of cholesterol medications, we're talking about exercises.
Right.
And the other thing is that the exercises are one of those things where, even if we talk about as we go into the next step, which would be surgery, if you have surgery for this, it doesn't get you out of the exercises, right? If anything, it makes it more important. But I'll digress. And so let's say that you do you do these injections, and the pain comes back. What other options are out there?
Like you mentioned, surgery. Right. So generally speaking, we can look at the statistics and say that about 85% of people suffering from radiculopathy will not need any surgical intervention. Some do. And why do some need surgical interventions? Well, a clear-cut subset of the population that has radiculopathy will need it sooner rather than later, because of the red flags, right? So those people that have the red flags, myelopathy, compression, significant loss of function, all of that really will expedite every step that we've looked at. Not necessarily jumping straight into surgery, but also depending on the proportions of the loss of the function.
Yeah, and the direction of the loss. Is it progressively getting worse, or is it steady? Has it kind of evened off?
And if absolutely, and if it's not a complete loss or a significant loss, and even if the pain is a major component, if this is progressing or just not progressing, it's not getting better. Physical therapy, ergonomics, posture, injections, everything that's been done, the next step is really in the continuum of care is to consider surgery. Surgery is really just another tool in the continuum of care, by escalating, not jumping to, but escalating. If that tool is necessary, then that tool is employed. And in my conversations with patients, I usually will tell them that we need to strike a balance between thinking that we need to jump straight into surgery, versus surgery is the last and the most dire thing to do. It needs to be a balance where it's just a tool.
And surgery in and of itself is a continuum, right? Not all surgeries are the same things. There are some surgeries that both surgeons and non-surgeons try to avoid, like the Dickens, because there's lots of complications. And there's other surgeries that are not that big of a deal, that like I've had, plenty of patients where I'm pretty sure that if we fight these, if we fight this cervical radiculopathy, we're going to get there. It might not be worth it sometimes. There are times when the pain is so bad and, the surgery is so small that it makes more sense for people, depending on the situation, to have a small surgery rather than to spend a couple of months fighting tooth and nail to avoid that surgery. It depends on the person and the situation and the kind of surgery you're avoiding. But to your point, a lot of times people just look at surgery as this black box to be avoided at all costs, and it's another tool in the toolkit that we just have to think about when it's appropriate to bring into the picture.
Absolutely. And to your analogy of the black box, it shouldn't be a black box. And this is where the conversation about do we consider surgery or not consider surgery really should be very realistic. And that's where I usually will advise the patients to talk to a surgeon.
Right.
Talk to a surgeon so that it's not a concept. It's not something that's really fear-inducing.
Right.
This kind of amorphous,
Right.
amorphous black box
Right,
where you
right,
don't
right,
know what's
right.
going on. This surgical approach may be something that you want to avoid, or maybe it's something, to your point, that's something that's minimal. And also, we have to take it in the context of the functionality, right? The biomechanics, because as we started talking about initially in our conversation, the pinched nerve, the irritated nerve, is not necessarily going to be this one entity because it exists within the context of the human body. Some people will start to compensate with different mechanics, and those mechanics will bring on their own problems. So in fighting tooth and nail to avoid surgery, you may get to the point where radiculopathy is no longer a problem, but along the way you've created so many different little problems that now you have to unravel that whole
Right.
whole thing.
And that gets into the whole clinical picture. We're treating a person, not a not a particular pathology, per se. And I also, to kind of wrap it up, but there's something I like to tell patients too is, sometimes the best time to talk to a surgeon is when you don't need them, right?
Yes.
Like it's nice to be able to have a conversation where it's an option and not a necessity, and to so that you can just know, all right, this is the whole playing field in front of me, because it's always better to make choices from a position of power, and that power is knowledge. And if you're, and sometimes fear shuts you down from seeking that knowledge. And the truth is, almost always in what we do and the kinds of things we're talking about, the fear is unfounded in the sense that we have good options, and it's good to know what those are, all the way through sometimes.
Right.
Did I miss anything? Anything else we want to talk about?
I'm sure we can dive deep into certain
there were
aspects.
some places.
Yes.
Yeah. Well, maybe for another podcast.
Right.
But all right. Well, thank you, and thank you, listeners, for listening. And we'll wrap this up. Have a good day.
Take care.